So our first speaker, I'm delighted to introduce John Finnerty. John is a thrombosis patient and he is here to share his story. A little bit on John. In June 2024, John was out cycling a 37-kilometer race. He felt fit, he felt healthy. The day after the race, that's when everything changed for John. What he thought was a simple pulled muscle turned into a blood clot. So John is here today as a patient and a survivor to share his experience of thrombosis. John has learned the hard way that life is random, but lives by the rule that we can't control what happens to us, only how we respond. So thank you, John, for joining us. You're very much welcome. And you can now come on the screen, John, and share your story.
Thank you very much, Mary. So my story starts on Tuesday, the 4th of June, 2024. So that's my dog Rocket there. So I'm a cyclist. So I'm a member of the Limerick Cycling Club. So every summer we have a series of races. It's usually 10 weeks in a row, about 40 kilometers in each race. So that Tuesday, the 4th of June, I was looking forward to that race. Also looking forward to the summer ahead as well, because that Saturday I was due to fly to Mallorca with my wife and my daughter. So I was really looking forward to that. So that Tuesday evening I went out, did the race, the 40k race, didn't win it, came in about 10th in the race overall. So I was really happy with that. So I went home then, I was delighted with myself and looking forward to the rest of the week and the rest of the summer. So I woke up the following morning then with a penetrating pain in my left ankle. And I really couldn't understand it because I hadn't injured myself the night before. So I didn't really know what to do, but I could barely walk. So I knew it was sore enough. So I was due to work that night on the Wednesday night, but I knew I couldn't go in because I was barely able to walk. So because I couldn't go in then, I would need a cert from work because I was going sick. So that day, the Wednesday, I rang the doctor and the secretary said to me that unfortunately, they were pretty busy. They wouldn't be able to accommodate me. So if it was still sore the following morning, to go straight into the hospital. So the following morning, that was the Thursday morning, I woke up and the pain was still there, a penetrating pain in my left ankle. So I decided then, I would go into the hospital just to get it looked at. So on the way into the hospital then, I stopped at my favorite coffee shop and I got out of the car. And then I just felt a real shortness of breath. I could barely breathe. And I really didn't understand this because I'd never experienced anything like this in my life ever before. So fortunately, I just didn't panic and I managed to regain control of my breath. But then I had a decision to make, should I ring an ambulance or just drive myself into the hospital? So I just decided on the latter. I would drive myself into the hospital. So that's what I did. So I drove into St. John's Hospital in Limerick, fortunately without incident. So I got into the hospital then and I got seen by a doctor pretty quickly. So she asked me a couple of questions about my leg and then about just what transpired with the shortness of breath. So she said, yeah, it was probably a blood clot. But she said, we don't deal with blood clots in this hospital. You'll have to go to the university hospital. So anyway, I was transferred then to the university hospital via taxi. And on the way then, I just suddenly realized, what if I get into difficulty here in the taxi? Like, what's going to happen here? But fortunately, I didn't. So I got to the hospital and then I was seen pretty quickly then into the A&E unit and then up to the deep vein thrombosis unit. So I was sitting inside there then, and this guy, he was a patient there as well, and he comes over to me and he refers to me as a doctor. And I said to him, look, I'm not a doctor. And he says, are you sure? I says, look, I'm quite certain I'm not a doctor. And even if I was to become a doctor, I would never have got the points in my leaving cert. So we had a laugh and a joke about this. So eventually, anyway, there was a scan taken my foot and it turned out it was indeed a blood clot. So then I went to see Professor Watts, who was there that day. So he explained to me probably a blood clot. It was unprovoked and that I would have to, take medication long term. So I said, that's all fine, and he said to me, by the way, he said, no flying for about 6 weeks. And I said, well, I'm going to New York on Saturday, and this was Thursday. And he says, no, you're not. He says, no, you won't be flying anywhere for about 6 weeks. So he said, look, you'll have to go home, rest the leg and take some time off. So I went home anyway, just to reflect on just what transpired. So about 2 days later, then I got another pain, and this time was in my chest. And that pain was penetrating pain as well. So again, back to the hospital, back in, series of tests, eventually had an angiogram a few days later, and that revealed I had a 40% blockage then in one of my arteries. So now I have two health conditions. So a blood clot and a 40% blockage in one of my arteries. So back home again, just to reflect again on what had transpired. So the next question is like, how do you deal with that? So one medical condition and then another one. And were they related? Well, nobody could say really if they were or weren't. So the thing is like, how do you deal with that? Like, and how did I deal with it? Well, if anyone who's studied psychology or sports psychology will tell you, you can't control what happens to you, but you can control your response. So my response really was rest. And my dog Rocket was absolutely delighted there, like, you know, because I was off work for a couple of weeks. He had me practically all to himself, and plenty of rest and take the medication. That's how I dealt with it, and reading as well, like all of the above. So in total, I spent 82 days off work. The pain in my chest eventually subsided as well. So it was probably my body probably telling me, you know, slow down, probably doing too much just to slow down with my whole lifestyle. And that's what I did. So after 82 days off work, went back to work again. And thankfully, everything is fine. I'm taking medication now and I'm back cycling and everything is practically 100% again. But for anybody listening out there at the moment, just to summarize, we have no control what happens to us in our lives, no control, but we have control in how we respond. So everything in life really is how we respond to these major events in our lives. Thank you.
Delighted to welcome Dr. Maeve Crowley, who's a consultant haematologist at Cork University Hospital, whose topic is all about clots.
Thanks, Mary, for the invitation, and apologies for all the words. So I'm going to try and simplify words today. I just want to start. I suppose I'm actually very happy that John's talked about two different types of clotting, because it was such an inspiring story, but also it really demonstrates about what sometimes words doctors use and what people understand by them, and quite often it's not very clear. And then also, obviously, this is the first year that venous thrombosis has come into the Irish Heart Foundation. So it's our first year together, and we're delighted to be celebrating World Thrombosis Day with the colleagues in the Irish Heart Foundation. So I'm here to talk all about clots, and hopefully we'll clarify a few issues. So I suppose, first of all, what is a blood clot? So if we think about the body, we aim to keep blood fluids in the blood vessels so that it can flow around and deliver oxygen. And then if a blood vessel wall is damaged, we want some kind of limited clotting to stop us bleeding. So we've got things in the blood that make us clot and things in the blood that stop us clotting. And these are really finely balanced. And if anything happens to throw this balance off, we can either have a bleeding problem or a clotting problem. So then we use the term blood clot a lot, and the cardiologists use it and the stroke physicians use it, and people talking about clots in the lungs and the legs use it, but actually quite often we mean very different things. So in medicine, there's this big difference between blood clots in your veins and blood clots in your arteries. So I'm just going to try and address that a little bit. So first of all, when we talk about blood clots in your veins, there's three big risk factors for it. So if the vessel wall is damaged, in the same way as that if you damage the surface of a non-stick pan, things are much more likely to stick to it. So you're much more likely to have clotting at that area. If there's something in the blood that makes it more likely to clot, the so-called sticky blood. So, and this can be something that's inherited, or it can be related to another condition that you have, such as pregnancy or cancer or being on the pill or other medications. Or if the blood flow isn't as good, because blood that doesn't flow quickly clots, and that's just a normal mechanism. And this is what's called Virchow's triad, and World Thrombosis Day is today in honor of Virchow, who first described this. In the arteries, it's a little bit different. We're much more worried about damaging the vessel wall, high pressure with high blood pressure, and other conditions such as high cholesterol and diabetes. And then sometimes we're worried about abnormal heart rhythms. And as you can see, so different things cause the different types of clotting, but we also treat them quite differently. So this is just a picture really to see that when you've got your arterial thrombosis, and when I say arterial thrombosis, I'm talking about things like heart attacks and strokes and peripheral vascular disease. Quite often you can have problems in kind of the vessel wall itself, and you get lots of platelets, which are the blood clotting cells. Whereas the venous thrombosis, so that's the clot in your leg, your deep vein thrombosis or DVT, or your pulmonary embolism or your PE. And quite often the vessels are okay here, or they're not underlyingly damaged. We've done something to them, like putting a line in or doing surgery, and that damage causes this localized clotting. And just from a bit of terminology, so if we have a blood clot in the veins in the leg or the arm, then we consider it a deep vein thrombosis. Whereas if it's a blood clot in the leg or the arm of the arteries, we call it peripheral vascular disease. So these are really arbitrary things, but they're caused by different things and they're treated by different people with different agents. So it's really important. So if you say you've had a clot, actually that can mean lots of different things. The same with if you have a clot in the lung, it's generally called a pulmonary embolus. Whereas if you've got blood clots in the vessels of the heart, we call it a heart attack or an MI. In the abdomen, if we're talking about a clot in the portal vein or the splenic vein or splanchnic vein thrombosis is the nice technical way to discuss it, when you're probably going to see a haematologist, whereas if you've clot in the renal artery or the splenic artery, it's likely to have other causes and other management plans. And then finally, stroke is one of the more interesting ones, because the classical stroke is a clot in the artery in the head, so you stop the blood supply into the head, and that can either be called a CVA or a TIA. But actually, if you've got a clot in the veins draining the brain, the venous sinuses, then we call that's a venous thrombosis or a blood clot in the veins, but it's still called a stroke. So really, we do as much as possible to confuse people into what they have. We use a very simple term to mean an awful lot of things. So as I said, it's really important for doctors and for patients to find out what type of blood clot you have, because the treatments are very different. So in general, if we're worried about a clot in the vein, then we're talking about using anticoagulants or blood thinners. So these be things like warfarin or rivaroxaban or apixaban or edoxaban or dabigatran. I'm trying not to leave out anyone, so I'm not favoring anything. Whereas quite often with clots in the arteries, we're much more worried about knocking out the platelets. So we use things like aspirin or clopidogrel or ticagrelor or multiple other ones. But then sometimes we'll use anticoagulants as well. So that's why sometimes someone will come to my clinic and go, oh, but I was on a blood thinner and this clot has still happened. And when they say they were on a blood thinner, it might have been something like aspirin or clopidogrel. And we know they're really good at managing clots in the arteries, but not so good at managing many clots in the veins. So that can be really confusing, because we use terms again like blood thinner very commonly, but we mean them as very different things. Whatever type of clot you had, though, it's really important to think about the risk factors for it. And many of the risk factors cross over between the two types. So it's trying to avoid them. I suppose John is doing as much as he can by staying active and looking after himself. But I suppose smoking is the one big one that covers both sides, and it's really important to try and limit or eradicate. This is a bit of a complicated slide, but I'm hoping that it will tell you why we treat them so differently. So if you look under the microscope at different types of clots, so the arterial clots versus the clots in the veins, and then the pulmonary emboli are kind of clots in the middle. And if we look under it, in all of them, there's lots of fibrin. And I suppose when you think about that, all that matters is that for fibrin, anticoagulants like warfarin and apixaban and rivaroxaban and stuff are really helpful. Whereas we look at clots in the arteries, we see there's loads of platelets, where there's very few platelets in these other type of clots. So that's why antiplatelet agents like aspirin and Plavix and stuff are really important in the arterial clots, but not so important in these types of clots. So whatever type of clot you have, history is really important. Now, for the rest of my talk, I'm going to focus on venous thrombosis because it's World Thrombosis Day. But if you have a clot, the most important thing, other than establishing the diagnosis when you come into hospital, is for us finding why you had the clot if we can, and think about what circumstance did that clot happen. Because this is really important for thinking about how long you'll be on your anticoagulants for. Because we're always trying to balance the risk of bleeding versus the risk of having another clot and that reward that that anticoagulant has. there's a risk with every drug. So we really need to make sure things are balanced properly. Now, sometimes if there's a risk that can be removed, so if it's after major surgery, if it's related to a pregnancy, or if you had cancer, but that hasn't been managed and is no longer there, then we'll think about taking away the anticoagulant. But it's happened and we have no clear cause for the clot, then we're much more likely to continue on anticoagulants. There's a huge number of risk factors for blood clots. And generally we'll find the last one because that will be the straw that breaks the camel's back. But actually there's loads of things that impact on it. So I think we're always kind of very good at things like a pregnancy or a surgery because they're really obvious and they're very kind of discrete moments in our time. But actually background issues like smoking and obesity and immobility are there in the background. We may not notice them, but they all add up and they all push up our risk of thrombosis. So we need to get rid of as many of these as possible, or at least reduce them to reduce our risk of having another blood clot. Family history is really important. And I suppose a lot of people associate family history with doing thrombophilia testing. So that's a blood test you can have done to see if there's any genetic causes for why you got the blood clot. They have some benefit, but actually we know that if we just ask you about your family, especially your first degree relatives, if you have no one in the blood with a family having a blood clot, your risk is lower of getting a blood clot if you've never had one than if you've got multiple people, and especially if those people had blood clots at quite a young age. And there is no blood test that is more important than that. So if your sisters and your parents have had blood clots, then you're at a much higher risk than someone who doesn't have that family history, and especially if someone was young. So that's why we're always very focused on asking about who else in the family has had a problem or who else in the family hasn't had a problem. Pregnancy is a really good test of our clotting system. So blood clots remain the leading cause of direct maternal death, and it's an ongoing issue. And this has been persistent for a long time. We invest huge amounts of money in trying to prevent them and to raise awareness because it's a really important issue. So blood clots complicate about 1 to 2 per 1,000 pregnancies. And even an uncomplicated pregnancy has all the components of Virchow's triad that I talked about earlier. So the lack of blood flow, obviously, as you've got a growing uterus, that makes the blood clot return or the blood return from the legs a little bit more sluggish. Anybody who's had a baby knows that there's an awful lot of endothelial damage happening no matter what way that baby comes out. So that's going to push up your risk of a blood clot at the time of delivery. And then a lot of things happen in your blood. So you get the so-called sticky blood in a normal pregnancy. And that's to stop you bleeding out, because historically that's how women used to die in pregnancy. They used to have large postpartum hemorrhages, and in some parts of the world that's still a big issue. So some of the natural clotting factors rise as you get pregnant, and some of the natural anticoagulants fall. So you're in that kind of sticky blood kind of situation for most of the pregnancy and for 6 weeks afterwards. As the complexity of pregnancy increases, so if you've got issues going on in your pregnancy, that's going to change things even more. If you're sick and in hospital, you may not be moving and there may be more stasis. If you're sick and need a surgery, then you may get more endothelial damage. Or if you've got other conditions, they may also cause your blood to be more likely to clot. So risk assessment and prevention are incredibly important. Blood clots and cancer are also a really significant issue. So they're considered to be the second leading cause of death in patients with cancer after the cancer itself. So we know that certain types of cancer are associated with a higher risk than others, but then also certain treatments are also more at risk than others. So it's really important to look at it. And obviously, if someone has had blood clots before, has a strong family history, we may give them some treatments depending on their risk to try and prevent a clot. Because we know that a blood clot diagnosis in cancer can interrupt your kind of surgical or chemotherapy journey, but also it's another diagnosis. And that really similar to what John said, he'd had one diagnosis and then he had another diagnosis. And when you start kind of collecting diagnosis, it can get very distressing and kind of it can all snowball. So it's really important that we know that this is an issue in patients with cancer, and sometimes it's preventable. So it's something that we need to think about. So we know that hospitalization and blood clots are very closely linked. Obviously, sick people are in hospital, and people in hospital are more immobile than those not in hospital. So it's not so much the hospitalization itself, it's why you're hospitalized and what happens. We know that about 2/3 of blood clots are associated with admission to hospital, and therefore it's considered a majorly potentially preventative patient safety issue. We're a little behind this in Ireland for a long time, but I just want to call out Anne-Marie O'Neill, formerly of Thrombosis Ireland, but now chair of our committee in the IHF for venous thrombosis, because she's really led the charge on trying to get this on everybody's agenda, government, the hospitals, the HSCs, and has been a huge advocate for the patient safety alert cards that are available everywhere and are now part of HSC strategy for warning patients about their own risk. So when you come to hospital, you should be risk assessed, and that would be the national policy. And that means that we look at your risks of a clot versus your risk of bleeding, and we try and balance them to see do you warrant some treatment? And usually in hospitals, that's low molecular weight heparin or injections. But sometimes you need them. Now, sometimes if you're having a surgery, it may not be appropriate to have it the whole time, but it's still something that we need to think about. We need to think about what is your risk and what's happening, and are we doing anything to make your risk greater? Anne-Marie's also led the charge on translating this, because we know that more vulnerable populations don't always have access to the information. So it's been translated into a number of languages and available via QR code. So we're giving people this really basic and important patient safety information in their own words so they can understand it. I think that's really important. Recently, they published the National Clinical Guidelines on venous thromboembolism, and this is the first national guidance that we've had on this topic. So it's really showing the importance that the HSC is now placing on venous thromboembolism, or blood clots in veins, and just a strategy on how we diagnose them, how awareness is raised, and how we try and prevent them. And I suppose, again, just so that doctors are aware of it, and that it's kind of, or pathways are put in hospitals so diagnosis isn't delayed. We've also worked very hard on our patient information leaflet subgroup about providing some simple to understand information on some of the diagnoses, and these are available on the HSC website, and I think on the Irish Heart Foundation website as well, just about different types of clots and different types of treatments that you might be on, because obviously you're told a huge amount of information in the hospital when you're diagnosed first, but we know that people only take on about 10% of what they're told. So it's good to take home some written information on things, and then either discuss it back at your appointment, or with your nurse specialist, or with your own doctor in your GP practice. But it's nice to have some things written down, so you're, instead of going, God, I thought they said that, but it's hard to remember everything. So I'm going to finish up there, but I'll be happy to take any questions at the end. Thank you very much.
Thank you so much, Maeve. That was incredibly informative and comprehensive, and a detailed look at clots. And your insights are very valuable for today's discussion. And yes, we'll hold the questions for Maeve until the end, but please do add them into the chat or the Q&A function. Our next speaker is Dr. Sinead Lynch. Sinead is a senior psychologist at the Mater Hospital, and her topic on today will be coping with the uncertainties after a clot.
Today, it's really about kind of sitting with that uncertainty after a blood clot. Because I think what I hear most from patients is that maybe they felt that they weren't an anxious person before, and now all of a sudden they feel they have this huge anxiety or this health-related anxiety. And I suppose it's just trying to navigate that, especially maybe having had a blood clot, because you can feel all of a sudden that most emotions can feel overwhelming, or that you're worrying or preoccupied with thoughts of what if this happens again, or maybe any tension in the body can be perceived as, you know, dangerous. And so I suppose uncertainty generally doesn't sit very well with us as human beings. I mean, a lot of the time, maybe uncertainty can be related to anxiety because it's really when we don't know what's going to happen or when we feel out of control that we kind of get this heightened anxiety. So I suppose the experience of having a blood clot may introduce a level of uncertainty into your life. And as I said, as humans, we don't like uncertainty. It makes us feel uncomfortable. And of course, it can evoke feelings of anxiety, stress, or fear. So I suppose just know that this is really normal because I think sometimes we kind of do this double-edged sword thing of feeling the unpleasant experience and then questioning why we're feeling it and almost asking what's wrong with me. But it's completely natural. And what I will share with you is that we're kind of programmed and wired to worry anyway. And so when something frightening happens or when we've experienced something that has been very scary, it can leave us feeling kind of off balance. So try to imagine uncertainty as being similar to the weather forecast. Okay, we can't always predict what the weather is going to be like, but we can certainly learn to manage maybe how to cope with the showers or ride the storm. So the first thing I want to introduce you to today is the idea of breathing consciously. So breathing happens without us having to think about it. It happens all the time, and it's not something we pay too much attention to. But actually, I'm sure you've heard of mindfulness, and this isn't so much just about mindfulness, it's just about your awareness in the present moment. So the reason we focus so much on the breath in terms of maybe meditation or in terms of mindful mental health is because our breath anchors us in the present moment. So right here, right now, our breath is coming in and out, and it's just happening naturally. But when you can kind of get a sense of the present moment and when you can really put your attention into the here and now, that's when you can regulate yourself when you're feeling overwhelmed. So it's in calming your body through your breath, you calm your mind. So I'm going to talk in a moment about the mind-body connection. But even now, if you were to just take a breath in and a breath out, and do that again, whatever way is comfortable for you. So for me, I like to kind of go in through the nose. And then maybe at first I go out through the mouth. And then I like to steady it a little bit and maybe go in through the nose and out through the nose. So breathing in and breathing out through the nose. And again, whatever's natural now, breathing in and breathing out. And we'll do a little bit more of this exercise later, but maybe what you've just noticed in this moment is that, yes, your breathing was happening naturally. Your concentration is on this presentation, so you're not focused on how you're actually breathing in and out. But you may notice that when you did breathe in and out like that, it brought maybe a sense of pause or calm. And I guess that's your first tool in this toolkit that I want to give you today. When we talk about anxiety, really, it's a normal human response to stress, okay? So we feel anxious at times, but it's more noticeable sometimes when you've been ill or when you are actually ill, you kind of feel vulnerable. And you may experience symptoms such as muscle tension, nausea, lightheadedness, or a racing heart, or sweaty palms, or a tightness in your chest. And really, that's all kind of the symptoms of anxiety. But really what's happening in that moment is, if you imagine there's a part in your brain, it's called the amygdala, and it's like the car alarm, okay? And when it goes off, it signals to the body, okay, we're in danger, someone is trying to rob us here, we're vulnerable. And really that's the cortisol and adrenaline running through your body, making your heart race faster, making your chest maybe tighten, your breathing speed up. But when you can actually notice that, okay, and you can just pause for 1 second, so you go back to your breath, breathing in, and breathing out. That's like putting the brake on, okay? So if you use that analogy of, okay, we all have these primitive brains. We all have this amygdala, which is like this kind of car alarm or house alarm in our mind. And what it does when it goes off is it fires off into the body a threat. And I'm sure you've heard or fight or flight. And really that's what it is. But in that moment, you can pause and you can decipher for yourself, well, hang on a second, what just triggered that response in my body? Did I have a thought that was, oh God, what's going to happen when I visit my GP? Or did something signal to me that there's a bit of a threat? Because often what happens with anxiety is it's difficult to decipher your physical symptoms caused by anxiety and what might be a physical symptom that you need to go to your doctor about, especially if you've had a blood clot. So I suppose it's maybe having that compassion and that understanding to yourself that, you know, that we have these minds and bodies that are connected, but it can be tricky sometimes for us to really know what has set something off. So it's always really important to check out a physical symptom with your GP. But one thing in that moment, going back to that toolkit of a coping strategy, is to just pause. So it's to take that breath in, a nice slow exhale out, and see if the anxiety symptoms then ease, because obviously at that point you might realize, okay, it is a stress that's going on in my body and I can do something about it rather than maybe needing to go to your GP. So again, just telling you more a little bit about that mind-body connection. Recovery from any illness or event involves both the bodies and the mind. So people often believe that the mind and the body are separate, but of course they're not. And we know they're not. You know, you only need to maybe listen to a can opening on a summer's day and feel, oh, I'm thirsty now for something fizzy to drink. So of course our minds and our bodies are connected. And research has shown that the mind and the body are closely connected and have a direct effect on each other, especially when it comes to our thoughts and emotions. So for example, you may have a thought that will then prompt, as I just said, a physical response in your body, which then may prompt a behavior. So for example, if I had a thought today, like this presentation is going to go awful, I'm so nervous about it, everyone is going to hate me, that will prompt, you know, the adrenaline, the cortisol, that fight or flight symptom into my body. My heart will start beating. I might get sweaty palms, and my behavior might be that I don't turn up at all to this presentation because I've had this thought that this is going to go drastically wrong. Now, that thought is not a fact. I mean, I can't tell whether people are going to like me or not, but the point is that we just need to be careful of what thoughts we're maybe signaling to the body, okay? And then your emotions can be directly felt in your body. So for example, if you are feeling quite low or you're feeling a little bit sad or something, you could actually be more sensitive to pain. And so it's just important to not try to separate your mind and your body, because that's really the first step to managing anxiety. It's about noticing, okay, I feel afraid, I feel anxious, I feel worried. Okay, so instead of maybe going around ruminating and thinking, you pause. And I always say the pause is just that breath that I said to you at the beginning. In, out. Try to regulate that nervous system straight away, and then maybe step back a little bit from what you're thinking or you're feeling. So as I said earlier, it's important to notice what thoughts you're having, because maybe they're not all facts. So you could have a thought like, I'm going to be sick forever, I'm never going to recover. And then of course that thought is going to impact your emotions. And it's important to be able to learn to step back from that thought. So how do you do that? Well, I suppose the first thing is to kind of decipher, okay, well, hang on a second, what thoughts am I having? So almost like you're imagining your thoughts like clouds in the sky, they're separate to you, and you're able to take this perspective on them. So maybe you're having a thought like, I don't trust myself because I miss the symptoms. But in actual fact, you can pause and say, well, hang on, how helpful is that thought? Because if I keep having that thought, all it's going to do is make me worry more. And all it's going to do is make me lose confidence in myself in terms of trusting my own body. So maybe I can reframe that thought. So we often talk about in psychology about how could we think about that differently? What would a different thought be? Or what might someone else think or say to me? Well, maybe one of those thoughts could be, I did eventually get help and I'm taking care of myself now, or I'm trying to do as much as I possibly can. I feel anxious, but I can pause and I know what to do with that, and I'm trying my best. So I suppose that's just one way in terms of reframing thoughts. We sometimes talk about distraction, and while I'm a kind of a more emotion-focused therapist where I'm like, no, sit with the emotion, see what it is. Another more helpful tip sometimes is just a distraction tool. So like, instead of getting caught up in a spiraling negative thought. You can just change the thought process, like, okay, I'm going to plan something like my next holiday, or I'm going to think about what's going on in the weekend. This is especially useful if you're lying in bed at night, because that's usually when the mind gets most busy around those anxious thoughts. Or you could count all the red doors on the way to something. You could start counting backwards from in threes, and from 47, and start imagining the numbers in your head. That's a very good distraction tool at night in bed. Or maybe think of 5 music acts beginning with A, B, and C. So there's lots of ways to distract your mind, and it's fine to do that as long as you're not ignoring maybe a bigger emotional situation. Another thing that you can do rather than just think is, yes, talk to something, maybe about anything other than the worry on your mind. So again, it's a distraction tool. Absorb yourself if you can in something interesting or fun you enjoy, or watch a film or a book, as long as you can keep your concentration. So I know with a lot of these distraction tools, they're just a quick guide, but in actual fact, sometimes the worry can persist. And I guess that's when maybe you need the support of a mental health professional, or maybe when it's not so good to distract, and maybe you need to sit in what the fear or the emotion is. So for example, and this is often the case for a lot of cancer patients that I work with, there is a fear of, what if I get sick again, or what if this happens again, okay? And I suppose, again, it's normal to feel this way. If you've had an awful shock in your life, again, just imagine the foundations of which are under you are a little shaky because of that fear. So I suppose for some of us, this can mean that you can have to live with the prospect of a clot reoccurring. And of course, then that's going to be significantly challenging for you. So again, you have to try to be a little bit more compassionate to yourself. That just means basically, God, I understand why my brain is going to be like this. You know, if this car alarm is constantly going off, I'm going to be a nervous wreck. So like, I understand that now, but I also understand that I've been given a tool that if I put the brakes on, which is a very slow breath in and a very slow breath out, that can calm my nervous system. So when you feel anxious, just remember the nervous system is prone to staying in what's called fight or flight. So that would be like, again, using the car analogy, that you're down on the accelerator and you're just in drive the whole time. But of course, that's going to be exhausting on the body and the mind. And so you have to learn to put on the brake. And so basically, in order to kind of compensate that parasympathetic nervous system, just think about it as simply saying, when I breathe in and when I breathe out slowly, that's going to put the brake on, and that's going to kind of close the window of the hyperarousal. So another really useful tool is name it to tame it. And sorry if I'm rushing, but I really want to share these tips with you. You know, when we're in our emotional brain, when we're in that amygdala, when there's that fight or flight and all we see is threat, sometimes it's so important to just say, name it to tame it. So naming it would say, yeah, you know what? I am anxious. I'm feeling really nervous right now. And when I do that, I almost naturally put my hand on my chest, because it's like a soothing. It's like, yes, I am anxious. When you name it, when you bring language into it, you're moving into your prefrontal cortex, and that kind of is the more logical brain. And so you're getting out of maybe that emotional spiraling of worry. Okay, so just even naming it to tame it, just kind of saying, yeah, I am anxious right now. And maybe it's just to yourself, or maybe it's to a friend, or maybe it's even in a kind of a prayerful mantra of like, yes, I am feeling this way right now. You don't need to jump to fix that, because all you've done in that moment is switched from being in that maybe more emotional place to the more kind of rational mind. Okay. And one of the quickest ways to also do this, so I gave you the idea there of when you breathe in and you breathe out slowly, maybe it's through the nose or through the mouth, you're putting the brake on. Okay. Square breathing, or any type of breath work where you kind of extend that out breath, is really going to regulate the nervous system. So we're going to try that now. Okay. If you sit upright, just with your back straight, and what we're going to do is we're going to inhale for 4 seconds, hold for 4 seconds, and exhale for 4 seconds, and try and repeat that. And if it helps, and if you're looking at a laptop right now or a screen, you might imagine, you know, visualizing holding along the top of the frame, and then down the side, and then exhaling down the bottom, holding up the side, inhaling again across the top. It just gives you an extra visual, but otherwise you can just listen to me. So when we're ready, we're going to inhale. So let's go 1, 2, 3, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. And return to normal. Now, if you found that was a little bit quick, you can always rotate that. We kind of can do a longer exhale. So for example, you might have in for 7, hold for 4, and out for 8. Really, it's that out breath, that release of carbon dioxide that is really putting the brake on. So I always say, if in doubt, breathe it out. Okay, so even if you can't fully remember the square breathing or the box breathing, just remember any sort of breath where it's like a nice exhale will really help. Another tip for your toolbox is just to think about small goals, okay? So when we feel overwhelmed, everything can feel all over the place. It's like going into a room that you've decided to clean in the house and you decide, oh my God, how am I going to tackle everything? Tackle one corner at a time. It's the same with your mind. So set small achievable goals, and this will give you a sense of control, and also it can help reassure yourself. It'll help you focus and give you a sense of that everything is manageable and more achievable. And then this gives you a small boost and some reassurance that not everything is out of your control. Because really, if I was to simplify this whole talk, it would be that as humans, we do not like to feel out of control. And we can't control what happens to us, but we can control how we respond. And the 2 ways I would say to respond is to remember that breath, breathe in, breathe it out if in doubt. But also be kind to yourself, that compassionate touch where it's just make that connection with yourself, understand that you've been through something shocking, and make the connection with others, because research shows that we have a better sense of well-being when we're connected with others, whether it's like in this group today, or maybe in a Thrombosis Ireland group, or maybe just with any friends. It's going to be helpful, and even though it might be difficult initially, it will help in the long run. Another way to keep an idea on things is to kind of keep a journal. So write down some of the concerns that you have so that you start to actually see what are related to maybe more physical health and what are related to more anxiety. And then you can start to notice the symptoms in your body. It's particularly helpful at night to keep a journal. You can do this brain dump where any concerns you have, you just put it down on a piece of paper and you get rid of it. And writing down your worries helps you to understand what you're worrying about and kind of find more perspective on it. Also, research shows that practicing gratitude helps. So whether you want to start putting in your journal 3 things that you're grateful for in your day, or maybe writing down one small thing that you were grateful for and spending at least 3 minutes on it, honestly, fast track our positivity in terms of positive psychology, should I say, and practicing gratitude is the fast track to happiness. And then just remember, in the end, it's never going to be a problem if you can ask for help. When in doubt, breathe it out. And for further information and patient support, you can contact the Irish Heart Foundation, who are now supporting Thrombosis Ireland through the blood clot recovery. As I said, we have lots of resources on video resources and on literature, so leaflets and pamphlets.